Good afternoon. Thank you for the opportunity to present our clinical trial, Repurposing DEI to treat bladder cancer. Bladder cancer is a common cancer in the United States with over 81,000 new cases annually. Approximately 50% of those cases will be muscle-invasive bladder cancer. We treat muscle-invasive bladder cancer aggressively with chemotherapy, followed by surgery to remove the entire bladder. Unfortunately, about 30% of patients, even after this aggressive therapy, will develop distant recurrence. That is, they will develop bladder cancer outside the bladder. And you may ask, how is this possible if patients have had chemotherapy and then have their bladder surgically removed? In these patients, they actually initially present with what we call micrometastatic disease. That is, disease outside the bladder that is too small to be seen, even with modern imaging like PET scans and MRI scans. And in fact, the chemotherapy that we give is designed to kill the micrometastatic disease. So you may ask, how do we know how well the chemotherapy works if by definition you can't see the micrometastatic disease? We can determine how well the chemotherapy works to kill the micrometastatic disease by looking at how well it works to kill the disease we can see, that is, the tumor that is in the bladder. So the tumor in the bladder acts as a surrogate of what's happening to the micrometastatic disease. In patients who have chemotherapy followed by surgery, and at the time of surgery still have muscle-invasive bladder cancer found in the bladder, they have an overall survival of approximately 3.7 years. In contrast, patients who have chemotherapy followed by surgery, and at the time of surgery, no tumor is found in the bladder, those patients have what we call a pathologic complete response and have an overall survival of approximately 13.6 years. So here we identify the problem that we seek to solve with our clinical trial. We need to improve the efficacy of chemotherapy such that patients will have longer survival. Bladder cancer is 3 times more common in men than women. We and many others believe this is contributed to by testosterone. So it is important to remember that testosterone binds to the androgen receptor. And then the androgen receptor moves to the nucleus and causes new proteins to be made. We know that bladder cancer has androgen receptors. We know that androgen receptor signaling promotes chemotherapy resistance. We also know that men who are being treated with testosterone-lowering agents for their prostate cancer have a lower incidence of bladder cancer. And we know that men who have both bladder cancer and prostate cancer and are on testosterone-lowering agents for their prostate cancer have a lower recurrence rate of bladder cancer. In the Holder lab, we have also shown that if you treat bladder cancer cells with chemotherapy in the presence of testosterone, in the bottom left circle, you can still see that those bladder cancer cells are alive. But in the bottom right circle, circled with the green circle, you can see that if we treat patients with chemotherapy in the absence of testosterone, those cells are dead at 3 days. Again, showing that by removing testosterone, you improve the effect of chemotherapy. This is exactly what we propose to do in our clinical trial. Patients who are receiving chemotherapy for their muscle-invasive bladder cancer will also receive a drug called DEI. DEI dramatically lowers testosterone levels. It is FDA approved and standard of care therapy for prostate cancer. We believe that by adding DEI to chemotherapy, we will improve pathologic complete responses. Patients in our clinical trial, we will enroll patients with androgen receptor positive bladder cancer. The primary outcome will be the pathologic complete response rate. Historically, this is only 35%. We believe we can improve upon that. An important feature to remember is that treatment is only 3 months for the chemotherapy and the DEI. So for each individual patient, we will arrive at the primary outcome at only 3 months. Additionally, this is a pilot study. We only require 32 patients. And so we believe that with a short time to the primary outcome and only requiring 32 patients, this is a clinical trial that can be completed in a relatively short period of time. I'm showing you here our budget. You can see most of the budget is budgeted for purchasing the DEI. I do want to note, second from the bottom, that we have also budgeted for patient assistance. We know from prior history of clinical trials that non-medical issues, social issues, such as unable to obtain transportation, can be a barrier to being able to enroll patients into clinical trials. And so we have budgeted to be able to assist patients with these social barriers to enrolling in clinical trials so that we can assure that we are able to enroll 32 patients required. Additionally, our department at Brown, the oncology department, is also excited about this clinical trial, and they have done a rare thing in committing $40,000 to this study so that we can have the total amount we need when adding to the $70,000 from Cures Within Reach so that we can conduct this study. I'm showing you here the clinical team. I am a physician scientist. I run a translational cancer research lab, and I'm showing you the lab members on the left. And I also treat patients in the clinic who have bladder cancer in a multidisciplinary clinic, and I'm showing you the other physicians on the right. Additionally, we will conduct the study with the Brown University Oncology Research Group, which has conducted clinical trials in over 80 types of cancers. And some of those clinical trials have led to practice-changing national studies. For our proposed study, if we see efficacy, and we believe we will then plan a phase 2 trial, which will be randomized in patients with muscle-invasive bladder cancer. This is the industry standard for showing that a new therapy is improved over an old therapy. But not only that, we will also plan a phase 2 trial for patients with non-muscle invasive bladder cancer and patients with metastatic bladder cancer. Thus, this proposed clinical trial will have depth and breadth of impact with over 700,000 people living in the United States with bladder cancer. Thank you for taking the time to listen to our pitch. We hope we can garner your vote to obtain funds to perform this very important clinical trial.